Ladies and gentlemen, we have to now welcome on stage Professor Sammy Ohene. I think he's so intelligent, he still looks very young. Right. Prof, over to you, sir.
Thank you very much. I'm glad you didn't ask them to do another round of clapping as you are wont to do. It's a great pleasure for me to be here today. And I'm just wondering why I was asked to give this lecture, the very first one. And I'd like to start off by saying a few words. Okay. About Professor Forster. Of course, you've been told who he was. And I'm only trying to mention the fact that I knew him personally. He was my teacher. And in our psychiatry rotation, we were in small groups of 4 at the time. And I happened to be one of the 4 in his group also. So I remember very fondly on Friday afternoons during our psychiatric session, we would go, he would send us to the ward to go and clerk patients and then come back to present to him. He was a very proper gentleman, impeccably dressed in his suit. And now looking back, I believe he has some obsessional traits. Professor Forster, stable. You could use a tape measure to determine the distance of the books from the edge of the table. They were always neatly arranged. He used to smoke cigars. Of course, he didn't do it in the room there or when there were people there. And the matches that he would use, even the used ones, were arranged in a very orderly fashion. That was the kind of person he was. Soft-spoken, but very serious yet friendly. I cannot say he's the reason I did psychiatry, but there's no doubt that he certainly made me even more desirous of becoming like him. Personally, during my psychiatry rotation, I should say I was a beneficiary of his largesse because he arranged for one of his friends, Professor Stephen Hirsch, in Charing Cross Hospital, to accept some students from the medical school for a psychiatry elective. And I was one of the people who took advantage of that. Now, why has this lecture been instituted in his honor? We've been told that already. And I've asked the question, why me? I still do not know, but here we are. So I'd like to first talk about mental health disorders as a whole. It's clear that they've been with mankind since recorded history. If you go into the Bible, the accounts of King Nebuchadnezzar and King Saul, as well as what Job went through, as far as I'm concerned, are modern-day descriptions of mental conditions that would fit the diagnosis of schizophrenia, bipolar disorder, and major depression, respectively. Nebuchadnezzar, who was characterized as with long nails and dirty and roaming about in the forest, fits your modern day roaming mentally ill person. Saul, the same David who would play the harp for him when he is depressed, when he became manic, he wanted to kill him. And Job, who would not become depressed after all the problems that he went through. As far as treatment of mental disorders are concerned, we know that before, whenever, as far back as 6,500 BC, there is evidence that people were using what we call trephination. They would drill the skull to supposedly drain whatever they thought they were draining at the time as a way of treatment for mentally ill people. But as far as centers, or what we are now calling hospitals, or at the time asylums, were concerned, the ancient Egyptians, in fact, I'm told that the facility still exists in Cairo today, dating back as far back as the 7th century, was where the first lunatic asylum was built. There's also evidence that Aleppo in Syria, where there's been so much death and destruction in the last 12 years, housed the first asylum in that part of the Middle East also. Those of you who are friends with the English language would probably know the word bedlam as a synonym for chaos. Bedlam, in fact, is the name of a notorious madhouse where mentally ill people were kept. And in those days, it was, apart from their pretense of protecting them, also for entertainment. People would go and watch the people fight each other or do funny things to each other for their own entertainment value. As far back as 1247, it took quite some time before the rest of Europe and the Americas caught up in the 17th and 18th century. In West Africa, the British set up Calabar with an asylum, and then Yaba in Lagos also, in the latter part of the 19th century. And Accra, what we now call the Accra Psychiatric Hospital, was set up in 1906. Earlier in 1887, the people had been kept in Victoriaborg, where the current printing press is, towards the High Street. And that was a place where people with mental disorders were kept. So a year later, they made a law in 1888 to kind of cover this. So in fact, the Accra Psychiatric Hospital was supposed to have been finished in 1905, but it stood empty for a year because they did not have water. And when that was solved, they moved the people from Victoriaborg to the Accra Psychiatric Hospital. Like asylums everywhere, people were shackled, the conditions were not the best for hygiene, and many of the patients were often malnourished. So, in other parts of the world, just like in Africa, specifically Ghana, People have always believed that mental illness is due to some spirit possession. And because of that, we've always had traditional healers who tried to cure mentally ill people by divination, by exorcism, by giving them herbs or whatever other means that they believed would help to cure these people. The belief in deities is widespread everywhere in the world. All communities have had it at one time or the other. And over time, science has made majority of people to move away from that belief. I dare say it is still alive and well in our country, as indeed it is in many other places today. But today our aim is not to determine what causes mental illness or does not cause it. Our aim is not to determine which treatments are effective or are not effective. All we want to do is, why do we need laws to carry out treatments for people with mental disorders at all? We need these laws because it tells people with mental disorders that they have rights and how they should be treated. The state commits itself to the well-being of people who have mental disorders by ensuring that their mental health is valued, mental health is promoted, and is protected. And we ensure that treatment and prevention of mental health conditions are primary. Mental health disorders are also to be taken care of in a timely, affordable manner, which should be culturally appropriate and of high quality. It should be free from coercion, and it must be accountable. In this day and era, you cannot go on the streets because you see some people walking about, you think they have a mental illness, and therefore you want to round them up and throw them somewhere. This has happened before. There was a time when you see the conference center, which we call the International Conference Center, was originally built for the Non-Aligned Movement Conference in 1991 or 92, if I remember right. And at the time, the talk was that roaming lunatics were making Accra look dirty. We were going to have visitors from all over the world, so we wanted to clean up the place. And clean up meant getting the military to go around, everybody on a looking disheveled, standing at a bus stop, would be forcibly put into the back of the truck. And after they had gathered a truck full, they'll bring them to Accra Psychiatric Hospital and come and dump them there and tell the doctors and nurses to put them inside. It was as crude as that. Now, mental health laws are meant to prevent things like this. I must say that at the time, there were some people who had closed from work, carrying who were added. The more they protested, the more they were convinced that they had mental illness. And after 2 days, when the doctors went round and said, "Oh, but this man is not sick." The man said he was only going home. He was working as a laborer somewhere. Because he looked dirty, they said he was a mentally ill patient. So mental health disorders are to prevent things like this, so that we should respect their rights and enable them to work and participate fully in society, free from stigma and discrimination. Now, mental health laws do not exist in every country in this world. In fact, at the last count, 131 countries, making up 68% of those who belong to the World Health Organization, have standalone policies which would regard as a mental health law. If you look at the ones for most of the developed countries, they are very similar. At least the criteria they use, the kind of treatment that they give, and the duration that is prescribed for involuntary commitment. This table is a table that shows by regions the numbers that have mental health legislation. Africa, 59% of countries do. In the Americas, 73%. Europe has the highest of about 96%. The figures on the right show those who do not have any legislation, as much as 41% in Africa, and only 4% in Europe. Now, let's come to the law itself. As I mentioned earlier, in 1888, the Lunatic Asylum Ordinance was enacted in the Gold Coast. That ordinance, for its time, was the best that you could find anywhere else in the world. It recognized that these people were of a special category and that they required special custodial care. There was a slight amendment made in 1940, the details of which are not available. But in 1972, Ghana enacted the first modern mental health law. In a sense, it was quite progressive because it recognized people with mental conditions as being medically ill. They were not criminals anymore. And in fact, that law had a provision for visiting committees, although I doubt whether they were ever set up. And even if they were set up, I do not remember or heard that they ever operated as they were meant to. And it's important to recognize that the law applied only to psychiatric hospitals because that is where people with mental illness were supposed to be treated. But the reality is that more than 95% of people had no access to these hospitals. Some had access, but they were not interested. They did not believe that that was where your problem could be solved. And so they never used them. Be that as it may, it was a great beginning for mental health legislation. In 2012, Act 846 became the new mental health law in Ghana. And let's not kid ourselves. This happened 40 years after the previous legislation. But believe you me, it took a lot of hard work, many, many, many years. Some people started agitation right from the 80s through the 90s. And from the early 2000s, there was a lot of lobbying and hard work and consultation. And eventually, the law was passed by Parliament to great jubilation by many of us. I remember that the last 2 years, after we had finished the work and we wanted it to be passed, Parliament appeared not to be very interested. There was, thank God for social media, a barrage of what you may call it. I remember reading a letter from somebody in Australia who I'm sure had never been to Ghana before, asking the legislators in Ghana to pass the mental health law. And all over the world, social media helped considerably in putting pressure, and this law was passed. And in fact, one of the parties had made it part of their manifesto promise. And luckily, when it was passed, it didn't take a few days for then President John Evans Atta Mills to assent to it on the 31st of May, 2012. So this legislation came into being, and it was soon hailed as one of the best pieces of legislation regarding mental health in the whole world. Because we've already been told about some things that were unique about that law. The object of the mental health law in 846 is, after establishing a mental health authority, the authority was to propose mental health policies and ensure their implementation. It was also to implement these policies, to promote and provide humane care in a least restrictive environment, and to promote culturally appropriate, affordable, accessible, and equitably distributed, integrated and specialized mental health care that will involve both the public and the private sector. So it was all-encompassing. They were to take care of the mental health of Ghanaians, period. Now, it was on the matter of integration. They were to create and use the existing facilities at all levels, from primary to national, and to provide multidisciplinary services in all communities, facilities, prisons, children's homes, educational establishments, anywhere there was a need for mental health services. They were also to prevent and treat mental disorders, to rehabilitate and counsel those with mental disorders. And they were also to ensure that the staff, the multidisciplinary human resource base, was well trained for the job. The aims of the Act were to ensure that rights and quality treatment of people with mental disorder was upheld. They were to stipulate changes in the organization, provision, and funding of mental health services. And they were supposed to emphasize community-based care. Some of its highlights, it was very strong on human rights, because for some of the laws in some countries, you know, one or two people could decide that this person is not well, and he'd find himself in a psychiatric hospital involuntarily. It was also unique because we recognize the fact that majority of the people did not use the formal services or hospitals that we had. They went to traditional and spiritual healers. It does not matter what your opinion is about them. That's where people went. And the law tried to ensure that even they would be regulated as far as their treatment of the mentally ill was concerned. This law also has provision for visiting committees and a review tribunal. So if somebody decides that the way I was dressed this morning, walking along the street, I look like a mentally ill person, and found some way, went and got a doctor, told him a story, and they took me to the hospital and admitted me against my will. There is a period beyond which they cannot keep me if I insisted I was unwell. And the tribunal would come, they would listen to my case, look at the file and all the evidence, and take a decision. So, people with mental disorders have rights that you cannot toy with when it comes to this law. It also establishes the mental health body, authority as the body that would organize and control all services in mental health. And it banned the use of physical restraints and chaining in all centers, including the traditional treatment centers and prayer camps. The focus of care was to move to the community. It also provided for a mental health fund to facilitate the care of people with mental disorders. Now, before 2012, that's what our mandate is. We are looking at what has changed, what has happened in the last 10 years. In 2012, Human Rights Watch published a rather damning report on mental health care in Ghana, with vivid images in graphic detail showing some of the terrible conditions and abuse that some people with mental disorders were subjected to. Many people in the mental health fraternity in Ghana complained about the bias. That is, they didn't mention anything positive, which was true. But we also all knew that what they depicted existed. If you take a look, oh, what a shame. It's a pity it's a little blurred, maybe because of the light. I wish that we would be able to see this. It's a man in shackles, in chains, tied to his ankle to a log, and the log is strapped to a huge bamboo, I think it's a baobab tree. He's lying on a mat. Maybe if this light were off, I don't have many pictures, you'd be able to see this. But this is the condition in which quite a number of people with mental illness find themselves. These are his legs down here. And the chain stretches to a bamboo across there. And you see the bamboo is strapped to the huge thing around there is a huge tree. There are many people like this, unfortunately, that you find in various parts of the country being treated like this. If you went to, even in Accra, there are a few herbal, traditional and spiritual treatment centers where you may find people in chains all the same. Now, in 2012, there were 2 psychiatric hospitals in Accra, Pantang and Accra Psychiatric Hospital, and 1 in Ankafo. There were 2 doctors who had had a diploma, 1-year diploma training, and community psychiatric nurses who run psychiatric units in 3 regional hospitals, Eastern, Upper West, and Brong-Ahafo, and units in a few district hospitals. Komfanoche had a small but active department where they admitted and treated or provided clinical services for people with mental illness. As we've been told, there were a total of 12 psychiatrists registered in Ghana. There were less than 20 clinical psychologists. There was no psychiatric social worker. There was 1 occupational therapist, and there were very few certified addiction specialists. At the time, our population was 26 million. Policy direction was dictated by the Ministry of Health in principle, but I must say that there was considerable input from somebody designated as the chief psychiatrist, which in a sense was an informal position. It was recognized, but they never made it part of the organogram. I guess so that whenever they decided that they did not want your advice, they could do without it. And it was important, I mention this because this individual and people around him, and I would maybe like to break protocol by, I'm referring to Professor Sari, who was then very instrumental, was in trying to decentralize mental health care. The doctors were not there, the psychiatrist was not there. So they trained a cadre of people called community psychiatric nurses, And they worked in the districts. Occasionally, psychiatrists would go and give support visits. Empowered by basic needs and Danida, they were the ones I can immediately remember. Funding for mental health was abysmally low. Ghana's health budget was about 3.6% of our GDP. But what was given to the health ministry, less than 5% of it ever came to mental health. So it's bad enough that health received that. But let's say that is what we have to share. But if you took all the health conditions, and there's data, overwhelming data to show that mental health conditions together show a considerable proportion of our health problems. But who cares? They got a paltry less than 5% of the health budget. So 10 years later, where are we? I like to look at these under these subheadings: administration, human rights, community care, human resources, integration of services, and funding. After all, these are the things that the Mental Health Authority is supposed to do. So under policy and administration, the Mental Health Authority has been set up. The policies are in place largely, but it is quite clear that implementation is lagging behind. The legislative instruments backing Act 846 were finally passed in 2019, about 7 years after the law came into operation. So forms have been designed, because if you want to take somebody into hospital under a certificate of urgency, or you think that he's a danger to himself or other people, there is still the possibility of doing that, but you must do it legally. And you need to fill forms, people have to sign, and so on. It took 7 years, but that has been done. And by and large, at least in the psychiatric hospitals, those are currently in use. On the issue of human rights, there's been extensive training and sensitization of a majority of the traditional and spiritual healers that we know, who have been treating people with mental health disorders. In the judiciary, some judges have been trained. I deliberately put that in quotes, because who am I to train a judge on the law? But having said that, it is also true that a lot of them are not, I should choose my words carefully, do not know very much about the mental health law. But let's even say they understand the technicalities and the language of the law. This is the law about mental disorders. If they do not understand what mental disorders are, the problem is still the same. So about 5 or 6 years ago, we conducted some training for a number of them, tried to explain in simple terms the symptoms that people with mental disorders would come up with. The fact that they may show this in their everyday life, it may be part of the reason why they may commit an offense, or you may see them in the cells doing things that other inmates may not do. They may come to court and put up certain behavior. But also stress the fact that if you have a mental disorder, it does not mean that all the time you will show symptoms. And so there are so many things to consider. Once they get that message, the thing to do when somebody is supposed to have a mental disorder is to refer to the experts. And I think that message went down fairly well. The problem is that the proportion of them who have been trained are relatively small, and a lot more has to be done. Now, in 2022, 10 years on, Human Rights Watch again visited 5 camps in 2 regions of Ghana. As a matter of fact, I met a young lady, a Kenyan lawyer, who works for Human Rights Watch last year during the World Cup. She had come on a follow-up visit about what was happening in the traditional healing camps in Ghana, about which they had reported 10 years earlier. This is a quote from their report. In one traditional healing center in Ghana, Human Rights Watch found 22 men in a dark, stifling room, all of them with chains no longer than half a meter around their ankles. One man said, "Please help us. We have a human right to freedom." And I'm quoting Chantarao Bariga of Human Rights Watch in 2022, just last year. So 10 years on, after the law has been passed, this law, which has been hailed as one of the best, which upholds the rights of people with mental illness, there is still chaining going on in some of the spiritual and traditional healing centers. I'm part of a project called the M-Healer Project. We started last year, carrying out research. The idea is to use digital means. An app has been what's the right word? Developed on a smartphone, which has videos of relaxation, de-escalation, and things like that, which we have supplied to a few people at the prayer camps. The idea is that instead of using force and physical restraints, they would learn to use these non-violent methods to calm down situations for various disturbed patients. After all, what they say is that if they do not chain them, they will, quote unquote, run away. And they might get into trouble because their relations have brought them there for treatment, and you've allowed the man to disappear. So they had no option. So this is to teach them some ways of de-escalation, some ways of controlling people without the use of physical restraint. As we're preparing for this research, our research coordinator, in trying to recruit the camps, went round the eastern, central, and parts of Greater Accra region, visited 26 camps, because we're looking to get at least 18. In all these camps, there were only 6 that they did not practice, chaining, even now. And this was only last year and beginning of this year. But where are we with involuntary admissions? Data from the Accra Psychiatric Hospital shows that there is a clearly definite increase in the referrals that come from the court system to determine fitness to stand trial or whether the person is culpable in the laws they've broken. And about the use of certificates of urgency are on the increase. So also involuntary admissions via court orders that have been initiated by the police or other people. This table shows the referrals from the judiciary to Accra Psychiatric Hospital. It's the main referral center that the court send people to. For 2011, I found only 3. 2015, I found only 1. Possibly there may be a few others. In 2017, there were 2. But you see, in 2022, there were as many as 17. And as at 3 days ago, we already have 14 from the court system. So people are using it. Clearly, the law is working. They are more aware, and they are doing what we would call the right thing. When we come to community care, what do we see? The MMDAs are the Metropolitan, Municipal, and District Assemblies, closely contiguous with the district, but not exactly. In 2010, there were 197 of them. Currently, there are 261 of them. And this is the table that shows those that have some form of community mental health service. It could mean there is a doctor. It could mean there is a community mental health officer. It could mean there's a community psychiatric nurse at the very least. So currently, 2023 shows that there are 261 of these assemblies in Ghana. And each one has at least one psychiatric nurse. I think personally that is a great achievement. Because what this means is that if we look at districts, all of Ghana is covered. I don't want us to be too elated because, as I said, a district may extend from here to wherever, 50 miles away. It may be inaccessible, but at least there is one everywhere, and we can build on that fact. What about human resources? There are 64 psychiatrists from 12, and I think that is a great improvement. The number of clinical psychologists has risen to 55. There are over 8,236 nurses. Unfortunately, there is still no dedicated psychiatric social worker. Having said that, I need to explain that there are some people who are very interested and a few who are engaged in the practice, who have been to social work school. But we do not have certified psychiatric social workers currently. From 1 or 2 in 2012, we now have 45 occupational therapists. And we have addiction nurses, in addition to a number of other people who have trained as certified addiction specialists. What I've noted there is that the increase in the psychiatrists, psychologists, and social workers and occupational therapists is not necessarily a result of the Act 846. But one, they've created the environment. Two, they've been able to provide employment for some of them. It's mainly because there's a School of Allied Health currently in the College of Medicine, and the social work department in University of Ghana and Cape Coast also train quite a number of people like that. We have got 5 regional hospitals that have psychiatric wings. There are 3 teaching hospitals that have psychiatric wings. Kolebu, Komfanoche, who they admit and treat patients. Unfortunately, the district hospitals for now have still not incorporated proper wings. The best they have is a unit there with some psychiatric nurses who attend to the patients. And I think 3 is correct for the number of private psychiatric clinics that we have in the country. I say that with a lot of care because I'm aware of 1 or 2 which are not run by psychiatrists, but which are operating all the same. I think that is a matter for my good friend Divine here to address. Now, this elephant. It's a pity you can't see again properly, but it's an elephant, which we all know is normally in the forest, in the bush. Unfortunately, there is an elephant in the room. That elephant in the room is money. 10 years after Act 846 passed in 2012, we've been told that the National Health Insurance Scheme will start paying for some services of people with mental disorders soon. The chief executive has said it. He has committed to before the end of this year. The president also said it when he was opening the department offices in Kolebu. There's no doubt that this will improve the situation, but it will only do so slightly. Because even before this undertaking, there's been virtually no money coming into mental health apart from the payment of salaries for staff. That's how bad it is. Organizations like UK Aid and Basic Needs, Danida, have been responsible for most of the mental health requirements in the country. Sorry. In the 3 public psychiatric hospitals, finding resources to even feed patients or carry out other activities is a huge challenge. Many of them depend on charitable donations to be able to care for the patients that are in the hospital. And some have resorted to, taking a deposit from the patient's relations before they admit them. Because we are still saying that the state is committed to caring for the people free at the point of service. And yet, in reality, almost no money comes in. My last bullet point there says the mental health fund has been set up, except that there's no money in it. So, where are we now, 10 years on? We have mental health professionals in charge of policy and implementation. Great. As I mentioned, some form of mental health service exists everywhere, every district in Ghana. Unfortunately, chaining of people with mental disorders in spiritual and treatment facilities remains a problem. At least we can say that it's not happening in the hospitals, thank God. But it should not happen anywhere else. Also, funding or the lack of it remains the greatest obstacle to improving mental health service. That is the elephant in the room I was talking about. A few facts about mental disorders before I sit down. They are responsible for majority of the daily adjusted life years that are lost in the working population. This is a term for measuring how much we lose in work output from people's illnesses. And if you take the top 10 disorders, from infections, from cardiovascular disease, psychiatric disorders, 5 of the top 10 are all mental health disorders, responsible for loss of working capability in any country in the world. This is work well known, done, commissioned by the WHO. And of these disorders, depression alone causes more loss of productivity in the age group 15 to 44, which is the active work group, than any other disease known to man. More than tuberculosis, more than diabetes, more than malaria, HIV, or whatever else you may think about. People with depression cause greater loss to our working abilities and productivity than any other disease, just depression. We've not talked of the other disorders. Another fact we all know is that mental health disorders affect not only individuals, but also families and communities. And if we don't deal adequately with them, it affects our economy and well-being. In fact, there is work by Professor Angela Oforiata and a few other colleagues that suggests that as much as 7% of productivity of GDP is lost by not paying attention to the mental health of the individuals that we have in the nation. So, what do we recommend? That we should continue to educate the key stakeholders, the judiciary, the police, and those who give care, including our own doctors, the non-psychiatric doctors, about this act. Many people are at a loss what to do when they are faced with somebody with a mental health problem that they think must be admitted, but don't know how to go about it. The law spells out what to do in all these situations. It will also teach people not to think that or believe that because you think that you are not happy with somebody's behavior, you can compel the person to go and take treatment. Unfortunately, that is not so. We should also educate the public on how to recognize symptoms of mental disorders so that prompt treatment, which we all know makes a great difference, can be started. And in that respect, I'm happy at the public relations campaign that the Mental Health Authority seems to have commissioned with all these celebrities and important people talking about mental health. The news has to be everywhere in the media so that everybody understands something about mental health. My perhaps most radical recommendation is that we must, by whatever means, fund this mental health fund. We must put money into it. And I will recommend a dedicated tax. I know people are tired and complain about taxation. But if you are not tired of all the problems that will arise when we have at least 10% of our population suffering from one form of disorder or the other, which affects not just the individuals, but the family around him. And if we are conscious of the fact that leads to loss of productivity and reduction in our GDP, then I think you will be sympathetic to the reality and will not mind too much if you have to pay 5 pesos, 10 pesos when you buy a bottle of alcohol extra to be put in the mental health fund. People have been gambling with reckless abandon. There is no reason why we cannot take some of that money into the fund. Because anyway, many people are also coming up with gambling addiction, which will become a problem which we have to treat. I know that happily not too many people are smoking anymore, but those who are smoking deserve to be punished by paying a little bit more tax. This fund will help to build infrastructure. We need a dedicated forensic, not one, forensic hospitals. Right now, they bring the people to Accra Psychiatric Hospital, which has no security for them. We need to ensure that people with autism and other childhood disorders have a place where they can go and be well catered for during the day, so their parents can go to work. There are many parents who have had to stop working just so that they have to look after one child, because the facilities don't exist. We need more clinics in the communities so that the psychiatrists that we are producing can go there and offer services, so that we don't have all of them staying in Accra Psychiatric Hospital. Otherwise, 10 years from now, we will have 200 psychiatrists, and yet the services will not be available. In conclusion, I'd like to make some observations that I think Professor Forster was a very brave man. I doubt that he had heard of psychiatry as a field of medicine before he left the Gambia to go and specialize as a doctor in the UK. I think he was also brave that he got married, a Gambian man got married to a Ghanaian lady from the Gold Coast. He was also brave. He left his country and moved to Ghana. It takes a lot of guts to do things like that. And you think about it, 70 years ago and more. And then to come and take a job in an asylum and gradually see its transformation into a hospital. So clearly he was a very brave man. And I think it's only fair that those of us who follow in his footsteps must exhibit similar bravery. We should not be afraid to take decisions. We must completely change the face of mental health in Ghana. And I'd like to suggest that Act 846 gives us a good template to start on. If we are able to implement all that it says, we will be moving forward in the right direction. But it's important that we act on it, so that 10 years from now, mental